But to link parasiticides to those is, I think, wrong. I think it's inappropriate.
Mm.
It's unscientific. It's unethical, and it needs to stop.
Mm.
It's a little bit like you sign up to a private health insurance for yourself, and you automatically get a dose of chemotherapy comes through the post every month just in case you get cancer.
Welcome to The Consult Room, the podcast where we explore the evolving world of modern pet care. I'm Dr. Paul Manktelow, a UK veterinary surgeon with a deep passion for pet health and welfare. In each episode, I'll be exploring key issues, challenging perspectives, and offering expert insight and practical advice. Because ultimately, my mission is to improve the lives of pets and the people who love them. Today's episode explores an issue that's starting to make waves in the veterinary world, quite literally. For decades, parasite prevention has been part of routine care. Monthly flea and tick treatments, regular worming, it's all being considered essential. But there is mounting research that suggests that some of the chemicals we use to protect our pets are also ending up in rivers and waterways, with potential consequences for the environment and for wildlife. To help unpack the science and what it means for both pets and the planet, I'm joined by Andrew Prentis, a veterinary surgeon with nearly 40 years of experience across private practice, charity hospitals, and academia. Andrew's career has taken him from treating working horses, donkeys, and mules in Morocco to running his own practice in London, and now to his role as a visiting fellow at the Grantham Institute for Climate Change and the Environment at Imperial College London. He's part of the PrEP group, producing rational evidence for parasiticide prescription, and sits on several national committees, including those for DEFRA and Vet Sustain, where he contributes to research on sustainability, ethics, and the environmental impact of veterinary medicines. Andrew, welcome to the Consult Room.
Thank you very much for inviting me. Pleasure to be here.
And thank you. And that intro just is really testament to how diverse your career has been. So, thank you for sending that through in advance. Andrew, on that, could you tell us a little bit about your background as a vet and how you came to focus your research on the environmental impact of parasite treatments? Was there a particular study or a movement that made you realise that this was an overlooked problem?
Yeah, I mean, as we were just saying a few minutes ago, I've had a sort of fairly checkered career, really. I mean, most of my work has been in companion animal practice, so dogs and cats in the UK. And I worked in various scenarios, private practice to begin with. I worked at the RSPCA, the big hospital in Putney, for a number of years. Took a bit of a detour via North Africa, looking after horses, donkeys and mules there. Back to the UK, back to academia, finally set up my own practice. And I had my own clinic, pet practice in central London for about 20 years. And what happened was that, and I've always been, it was nature that got me into being a vet. As a child, I liked nature and natural history. I liked the animals, and in that time working as a vet, I always had one eye on the environment, thinking that we and the animals we treat exist within an environment. We need to look after that environment. And I was just had this sort of niggling feeling that we were giving an awful lot of parasite treatments to these cats and dogs, most of whom seemed to be completely free of any symptoms of parasite disease. They may have had other stuff going on, and some of them, flea dermatitis or whatever, and that was happening. But in general, there'd been a shift to where instead of treating on a reactive basis, this animal has a parasite, we must treat it now. Well, so it kind of just shifted over time. So we were treating everything all the time. And I was just a bit uncomfortable about that because I was thinking, hang on a sec, that not many of these animals have symptoms of being sick due to the presence of parasites. So that was going on in the back of my mind. And I was talking to the team at the clinic and saying, I think maybe we're not that keen. I'm not sure we should be using this much of all these products. I remember very clearly my head nurse at one point saying to me, Andrew, you're going to put yourself out of business if you're not careful. And I thought, well, maybe, but I'm uncomfortable. We didn't go out of business, actually. It was fine. And the more we talked about that sort of element of precaution about treatment, the more people seemed to like the clinic and came to the clinic. And it was, we were busy. It was fun. In that context, a few years ago, there was a vet called Rose Perkins who published a paper where they had been looking at the rivers of the UK and looking for chemical contaminants in there, and looking particularly for two chemicals, imidacloprid and fipronil, which are very widely used as parasite treatments for cats and dogs, as you well know, and found that 99% of these rivers were contaminated with one or two of those chemicals. And that was a bit of a, it was a bit of a shock, actually, because I was thinking, oh, well, maybe there is something here. And I looked up an old friend of mine from many years ago who works at Imperial College. She works in the Centre for Environmental Policy. And I said to her, I said, just there's this thing going on in my head. You know, I was now not in clinical practice anymore. I'd stepped aside from that. I said, I'm just a bit concerned. We were using a lot of this stuff. And then Rosa just produced this paper saying they're all over the rivers. Do you know anything about this? And she said, okay, you need to meet Guy Woodward and Leon Barron. Guy Woodward is a professor of ecology at Imperial, and Leon Barron is a professor of, I forget the title now, he's an environmental chemist, basically, analytical chemist, forensic analytical chemist. And we sort of met up, and they went, and I talked to them about my concerns about imidacloprid and fipronil. And they kind of went, oh, that's where it's all coming from.
Oh, they didn't know. That's really interesting.
Hadn't
Isn't
really sort of put the whole thing together, because
Right.
there's imidacloprid particularly, which is a neonicotinoid insecticide, banned in agriculture. Fipronil banned in agriculture because they were having such a terrible impact on bees. It had been banned several years previously, and they said we're still picking up in the rivers. Imidacloprid has the highest ecological risk rating of all the chemicals we look at.
Wow.
It's you lot, isn't it?
Wow. And it's amazing they hadn't made that link, isn't it?
Guilty as charged. So they were all over it like a rash from the sort of ecological and the chemical and environmental perspective. But they didn't, I don't think they knew any vets. Didn't know about the veterinary profession, how we work as a profession. So that's kind of where it started.
So from this sort of, obviously you've connected the dots there, but how do these drugs make their way into the environment from our pets? Can you just talk through that process?
Yeah, well, and this has become clear from further work that's been done by Rose Perkins, or now Dr. Rose Perkins. She's got a PhD studying this, looking at how this happened. And fipronil and imidacloprid are both water-soluble drugs, and we are applying them to the outside of pets, so onto the skin, onto the hair at the back of the neck, typically. And we now know that those products can continue to be lost from the coat of the dog or cat for at least a month after application. Right. So there's a number of things happen. First of all, you open the little sachet, the little pipette, you put the drops on, and you get a drop on your finger. So you go to the tap, you wash your hands. Okay. So a tiny little bit down the drain, first of all. Second thing, over the following month, you're going to touch your dog or cat quite a lot. You caress them, stroke the back of the head, da, 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 da. You can't see it. We didn't know about it, but we do know now that each time you do that, there's a little bit of that chemical is on your hands. All right. So the next time you wash your hands, down the drain. Cat or dog comes to sit on your lap. All right. They're shedding this chemical all the time. Next time you wash your clothes, a bit more goes down the drain. You wash the dog's bedding, a bit more goes down the drain. You wash your dog, more goes down the drain. And cumulatively with what, 25 million cats and dogs in the UK, the quantity actually going down the drain becomes very, very significant. And it goes straight through, what I should say also is it goes straight through the wastewater treatment plants. So the sewage works goes straight through. And so we now know, we've done a lot of plotting of where these concentrations occur down rivers, and the highest concentrations that we found, or in fact looking at data from the Environment Agency, so this is government data, a lot of it is not generated specifically by us. The highest concentrations are in rivers in urban locations. So that's where people are, and where people are is where the pets are. So it's not agriculture. And secondly, within a given river, the highest levels by far are just downstream from water treatment works, sewage works. So you go above the sewage work, very little. Below the sewage work, bang, there it is. And yes, and so we've done a lot of sample. Well, I say we, our group, the members of our group have done quite a lot of sampling work, but a lot of the data that we've worked with and modeled with has come straight from the Environment Agency, who have been monitoring the levels of these drugs as a sort of a legacy, really, from the years when it was used, when they were used in agriculture.
So these residues get into our waterways. What do they actually do? What's the impact on the ecosystem and the biodiversity?
Okay. Well, these medicines are designed as insecticides.
Hmm.
They're pesticides. They're designed to kill insects. So they're designed to kill fleas and ticks. And so they don't distinguish between a flea on a cat and a little tiny bug in the river. And the rivers are full of invertebrates. So the tiny little winky things that are just running around in the river doing river things. And if the concentrations get above a certain level, the lowest levels, you'll get changes to their behavior. So these little invertebrates that should just be going around eating stuff and breeding and doing insect things, their behavior changes, and either they become a bit sluggish because they're a bit intoxicated, in
Right.
which case they are easier prey. So the
Nice.
bugs that eat them can find them, can catch them more easily. Or in some cases, they become a bit hyperactive and they're sort of dizzying around, in which case they become more visible, in which case the bugs that eat them can see them more easily. So they become more vulnerable, or they die if they get to higher concentrations. And so in every natural environment, you've got the food web, you've got the food chain. And these little invertebrates in the river, if there aren't enough of them for these reasons, then the ones that feed on them have got nothing to feed on. And the bigger ones are fed on by bigger ones, and then the fish eat the bigger ones, or other insects eat them, and then other fish are fed on by birds, and so it goes up the food chain. And if the food source at the bottom is being diminished, then the levels all the way up the chain start to drop off.
We often sort of frame parasite control as I guess, a one health issue, don't we? So it's protecting pets and people from parasites and the zoonotic elements of some of those parasites. But I just wondered how we balance that with the one health sort of risks of environmental contamination. Well, because it adds another layer, doesn't it?
Yeah, it does. It does. And the One Health thing is clear. It's people, animals, environment, and how we try and balance those things together. So in this context, the first question is, what's the health impact of the parasites? And if you talk to people about fleas and worms and all this kind of stuff, the initial reaction is, I don't like those. I don't like the idea of them. And we have quite good data on how common these parasites are. Some of it's a little bit conflicting, but we have a pretty good idea what proportion of cats and dogs have fleas or ticks at any one time. But the question for me is not really that. The question is, what's the disease impact? Does it matter, actually? If your dog has worms, roundworms, does it matter? It only matters if your dog becomes sick, is ill because they have roundworms. And you ask any vet in practice, have you seen puppies and kittens that are sick due to roundworms? Of course you have. We do. It's a standard thing in puppies. But if you ask the question, how many adult cats and dogs have vets in practice seen who are sick due to roundworms in their intestines? Not very many at all. In fact, I'd struggle to think of them. And maybe in cases of severe malnutrition and neglect and cachexia but actually in normal healthy animals, this is not a problem. So the next question is, how many people get sick due to the presence of roundworms? And people who follow this kind of argument, it's Toxocara larva migrans, it's the migrating larvae.
You can get in your eyes. Yeah.
They go in your eyes, all children go blind, and
Yeah.
it's a very good argument. It's a hazard associated with roundworms. But if you go to Public Health England or the National Health and do a search to find out how many cases of these migrating larvae causing a disease in people, how many cases are there? There was a survey published through the British Medical Journal, the BMJ. It was a subsidiary publication. It was the Drugs and Toxicology Bulletin, I think it was called, just last year. asking the question, how big a problem is this toxoplasmosis in people? And the health records of the UK threw up 106 cases, okay, where people had been diagnosed with an illness associated with roundworms. 106 people over the last 46 years.
Wow.
Right, so that's 2.3 cases a year.
Mm.
Okay, out of a population of 70 million people. It's rarer than hen's teeth.
Mm.
So the hazard is there, okay, because it's a potential problem, but the risk is absolutely tiny. And the human medics would find it absurd that you treat 25 million people multiple times a year to avoid 2-3 cases.
So how have we got to this place then? Because I mean, traditionally vets have advised sort of blanket prevention, you know, your monthly spot on, you're worming every 3 months, year round. Apart from yourself, as you've explained, you sort of booked the trend on that a little bit. Why has the profession always sort of taken this always on approach? So what was the thinking behind it?
I think, well, it was twofold. I mean, one is that rather like the way we used to deal with antibiotics, everybody uses antibiotics all the time. Miracle drug. Before the Second World War, if you get a minor infection in a cut in your leg, you could end up losing a leg. You know, I mean, it was antibiotics changed the perspective completely. So with parasite treatments, suddenly we had these that were extremely effective, and actually, well, animal without parasites, animal with parasites. Which are you going to go for? Well, we'll get rid of the parasites. Well, and we genuinely did not know that there was so much environmental contamination going on. I think that was the thing that changed it. When the analytical technology changed, and so we had people like Leon Barron at Imperial who were able to find these incredibly small quantities and concentrations of these chemicals. And suddenly people began to join up the dots and go, whoa, hang on, maybe this is not so good. I think, I mean, I was first in practice back in the 14th century. I mean, back in those days, we treated on a much more reactive basis.
Yeah.
And the treatments were horrible, difficult to give, and, you know, a pain in the neck. So you didn't really do it on a regular basis. But then the treatments became easier to give. And I think it then it developed into a sort of practical habit that we all had.
It's interesting, isn't it? Because I guess in the model of veterinary sort of medicine, we want to keep pets healthy, don't we? And as culturally in the UK, we use phrases like prevention is better than cure. You know, it's a really classic phrase, isn't it? But I think
absolutely.
you yourself have worked in the charity sector, as I have for, you know, best part of my career. And the model's quite different, isn't it, to private practice, in that in private practice, you are generally more focused on preventive medicine to keep the animals healthy. But in charity, you often see where prevention hasn't even happened, or and you see a lot more cases of disease. So really heavy flea infestations. You know, we used to see a lot of lungworm actually when I worked in southeast London, and also the diseases from, you know, as a result of pets not being vaccinated, like, you know, parvovirus. We had a bit of distemper as well when I was working in East London. So you're often treating, aren't you, rather than preventing. But even in the charity, there was still this drive to prevention is going to be better. If we can get these you know, these owners to be giving this, you know, parasite treatment really frequently, then we won't see that odd case of flea infestation. So it's really interesting, isn't it? Do you think there's a model to go towards something more risk based? Because what's the alternative to that sort of blanket?
Yeah, exactly.
Model?
And I think that's exactly it. So I'm not sitting here arguing that we should not treat parasites. I think what the argument is that we should not be treating blindly and just handing them out like sweeties, because these are medicines that do potentially have environmental consequences. The key to it is don't treat either have absolutely zero risk or very, very low risk, or have no symptoms, or you have tested and don't have any sign of parasites. I mean, what our group and those of us who are sort of active in this field, I think, would really argue for is, well, let's either test or risk assess. And let's try and assess what does it, you know, when a given cat or dog comes into the consulting room, can we figure out a way to do a quick half a dozen questions that you can ask quickly with simple answers, um, that will determine whether this animal is likely to have parasites, may or may not, or almost certainly doesn't. And those that have very, very low risk. When you look at the statistics and look at the amount of information and data we have,
Mm,
those low risk cases are probably in this country, very, very low risk. Now, we're very lucky in this country. We have a very temperate climate. We have a relatively low incidence of parasitic disease for cats and dogs here. This wouldn't apply in different climates, in Australia, in various states in the US and places like that. The
mm,
situation, the circumstances can be extremely different. But for what we have here, so there are ways that you can test. And if we're talking about fleas and ticks, I'm a big fan of a flea comb. You can buy a flea comb at the pet shop or a knit comb from the pharmacy, and you can check your cat and a dog easily on a regular basis. And if you find fleas or flea dirts, well, there's a pretty good argument for treating.
mm,
But if you find nothing, well, maybe do nothing. I think the levels of treatment need to match the level of disease. And actually, the level of parasitism in this country in general is fairly low. You just mentioned lungworm, which of course lungworm is the sort of the one that stands out because
mm,
lungworm is potentially fatal.
mm,
Fleas, itchy dog, not a big, roundworms, not really much, but lungworms is
mm,
potentially fatal. Overall, nationally, the figures are very low.
mm,
There have been various surveys done, and the commercial veterinary laboratories do have a reasonable amount of data about the incidence of lungworm in the
mm,
samples they look at. So we know a reasonable amount about how common lungworm is, but what we don't know, and this is a major fail. Well, it's a failing, I think, of our profession. What we don't know is how many dogs actually are sick due to lungworm.
mm.
It's not recorded anywhere, and we don't actually have any really good evidence for that. And I think if we were to talk at some stage about what needs to be done, then I think that would be a really helpful
Mm.
try and put together some data on that so that we are actually treating really in response to disease.
Would you recommend any other sort of that you mentioned there, sort of taking a risk-based approach by asking a series of questions? And I know when we consider, there's a lot also at the moment about over-vaccinating our
Yeah.
pets, and one of the alternatives to that is considering, blood tests to look at immunity to the disease we vaccinate against, which for some people isn't practical in terms of, you're then having to get your pet to have a blood test, which is an invasive procedure. There's the cost associated with it. It's quite, but if you feel very passionate against it, then absolutely that option's there. Is there anything that you could suggest that, practices could use in a really easy way to check whether or not parasite treatment's needed rather than just a questionnaire sort of approach?
Yeah, and I mean we're trying to sort of sort out what's the easy way to try and deal with the situation. I mean, just picking up on what you're saying about vaccination, because in my clinic we did quite a lot of work on that really, and
Mm,
and it just came out of a general concern about possibly over medicating, and we did.
mm,
I worked quite a lot with the late Professor Michael Day down at Bristol, who was a leading light in this world of vaccination. And we started blood testing before vaccinating.
mm,
I did that on a sort of experimental basis initially, and then published some papers on it, and it instituted it as a standard thing. If you bring in your dog for vaccination for the annual booster, then we would, in almost every case, take a blood test first.
mm,
And it was a question of just changing behavior. And it got to the point where the pet owners were used to the idea that they'd have the consult with the vet, and then one of the nurses would take the dog down to the prep room, take a quick blood sample. 2 or 5 minutes later, the dog would be up. Everybody's happy. The owners got used to the idea of testing. Um, the It didn't take more veterinary time because that's one of the
mm,
pinch points always in clinics. The
mm.
nurses got really, really good at blood testing all the time. And in the large majority of cases, the results would come back and say, okay, this dog has adequate levels of antibodies to
Mm.
distemper, parvovirus, and hepatitis. No vaccination for those three required this year. The reason I mentioned that it was that
Hmm.
it's a question of changing the mindset. And unfortunately, we have a situation where there are two things which are sort of problematic around this at the moment. And these come in the context, by the way, of the British Veterinary Association saying we should not blanket treat. We should not be treating every animal regardless. And the Royal College of Veterinary Surgeons in the practice standard schemes also says now it's an obligation. It's not advisory, it's an obligation that we don't blanket treat every animal. So it's a question of changing our behavior and expectations. And the two blocks that I see it here are these. The first one is that unfortunately we have a pharmaceutical industry that's got quite a lot of skin in the game here. The sales of these products are a very significant part of their revenue stream, and they've built it up over the years. To lose that revenue stream would be very damaging to their business model. So, in that context, there's an awful lot of advertising for parasite treatments in the veterinary press, in the pet owners press, a lot of representatives coming around to veterinary clinics, handing out lunches and, incentives. So there's a lot of push from there. And the other one is these monthly pet health clubs that are so popular and so much part, certainly, of the larger veterinary group business models. Call it what you will, the pet health club, the healthy pet club, the whatever it is. There's loads of them out there where
They
you
have
pay.
they have a sort of parasiticide built into them often a lot of the
Yeah,
time, don't they?
yeah,
Yeah.
yeah. And I think I would. I'm trying to state this as, diplomatically, but firmly. I think it's absolutely wrong to link parasiticide treatment with these known toxic pesticides. They should be linked to a monthly health plan. Monthly health plans, great, fine. It helps the client. They get discount on certain things at the practice. It's good bonding for the veterinary from the clinic's point of view. But to link parasiticides to those is, I think, wrong. I think it's inappropriate. It's unscientific. It's unethical, and it needs to stop. It's a little bit like you sign up to a private health insurance for yourself, and you automatically get a dose of chemotherapy comes through the post every month just in case you get cancer. I mean, it's not backed by science. It's wrong. We know it's causing a problem out in the environment. We have to figure out a way of changing our behavior around that.
You mentioned that industry does have a big stake in this. Do you think pharmaceutical companies are doing enough to research? Ultimately, is it their responsibility to research the risks and innovate safer alternatives, for example, that don't harm the environment?
Yes, and they are doing some, but there is evidence where the information given out on some of these products is just plain wrong. Okay, so thinking about some of the the spot-on preparations, and if you look at the data sheets and you look at the package inserts on there, we're not naming any names, obviously, but there will be in black and white, in writing in the insert, which is for the owner to read, would say, don't let your dog swim for 2 days, 3 days, 4 days after application. Well, there is now peer-reviewed academic papers describing research that clearly shows that these products are lost to the environment for at least 28 days after application. We've been doing a project here in London up on Hampstead Heath. There are a number of ponds on Hampstead Heath. Some are for human swimming, some are for dog swimming, and some are not for swimming at all. And we've sampled the water from all those ponds, and the ones where the dogs go swimming have high levels of imidacloprid and fipronil, and the others don't. I mean, it's so. Your question is: are the pharmaceutical companies doing enough? No, because those data sheets are wrong. We know they're wrong. They need to be changed. That said, there is a shift in patterns of use of these medications. So whereas it used to be all preparations put onto the coat, there's a shift more and more towards tablets and to a different medicine class. So the ones we've been talking about this last half hour are these neonicotinoid drugs. There's a shift to things called isoxazolines. So these are Floralana, Lotalana, and so on and so forth. which behave very differently in the environment. Now, if you take one of these in pill form, first thing to know is that the large majority of it comes straight out in the poo 24 to 48 hours later. So it's another very good argument for bagging and binning dog poo. And if anybody watching this has any doubt about that, it's really important for environmental protection as well as just for sort of the look of it. So the first thing is it goes straight through. If any of it does get into the environment, these chemicals, these isoxazoline chemicals, they behave differently. They're not water soluble, they're lipid soluble, they're fat soluble, which means we don't find them in the rivers, which, that you think, oh, well, that's good news. Oh, they're not in the rivers. Hooray. That means is they go into the soil, into the earth, and they stay there. Right? Because they don't leach out in the water because they can't. They're bound to the lipids in the soil. And the other thing about them is there's a group of chemicals out there called PFAS, which are the so-called forever chemicals. And these are ones they have chemical bonds between carbon and fluorine, which are incredibly tightly bound. They don't break down. Forever chemicals, they stay. So if your dog's had a poo in the park and you kick the poo into the bushes and don't pick it up and put it in a landfill, actually that poo, which is laden with one of these parasiticides, will stay in that soil probably for the rest of time.
Wow.
So, so it's all good news from me at the moment. But no, it's another argument. If the question is, well, what should I do now to treat my pet? Then I would say, please don't use a topical spot on treatment on the coat. Please, whatever it is, don't use that unless you have no alternative.
Right.
If you do need to treat, and you can, then give something that's given either by mouth or by injection. But if you're going to do that, be very careful with what happens to the poo. And don't flush your cat's poo down the toilet.
It's really interesting, isn't it? Because I think, knowing the profession as I do, and we are an evidence-based profession, as this research is coming out and there's potential, implications on the environment, most vets, I feel, would respond to that with concern. So do you feel like the profession is responding to this research in the right way by changing the recommendations and trying to change the habits of owners? Or do you think there's a bit more pressure from, practice owners, whoever they might be, or client expectations to continue with that sort of blanket approach? Where do you feel we are right now as we sit here today?
I think we're a long way ahead of where we were even just a few years ago. Actually, I think the profession, the regulatory bodies, so the British Veterinary Association and the Royal College of Veterinary Surgeons have come out quite strongly with policy and guidelines and expectations around this, which is good. There are a number of resources for the general public. There's a group called Vet Sustain, and this is of vets and vet nurses and veterinary professionals who are interested in sustainability issues. Vetsustain.org is the website, and on that now is a resource about this whole issue of parasite treatments. Our group at Imperial, we call ourselves the PrEP group. PrEP stands for Producing Rational Evidence for Parasiticide Prescription. It's academic nonsense, but the PrEP group at Imperial, we also have guidelines out there. There are things appearing in the media. You've asked me to come and speak on this. There is more awareness of what's happening. But we've got these two pinch points, which is unfortunately are both basically commercial pressures. And one is about the people who are producing and selling these products, and the other is about the business models that involve monthly schemes. Now, there are people out there are outliers who are now developing these monthly subscription schemes for clients that don't automatically involve parasite medication. It's starting. And it will change. I'm very confident that it will change, and I'm confident that we will learn more about this as time goes by. We'll get more data. There's lots and lots of research. If anyone out there is interested in doing more research on this, we've got plenty of projects that need to be done. But I think we will learn more. The profession is moving in the right direction. We've seen a big increase in awareness The rest of the industry is perhaps dragging its feet a little bit. And of course, something we haven't mentioned at all yet is that there is widespread availability over the counter of many of these parasite treatments.
Right. Yeah.
And I think we need to be very careful about that. These are not trivial chemicals. They are
Mm.
very effective on your pet for a very good reason, is that they kill insects.
Yeah. And I was going to ask you about regulation as well, because, and whether or not these drugs should even be available over the counter is a question that I'm sure many people listening would feel very strongly about. But I know that some European countries, and I found this out because a good friend of mine who's got a dog in Spain texted me because he has been told by his vet that he has to present his dog every time he wants a parasite treatment. And I know in Spain they've been quite heavily regulated, haven't they, around antibiotics as
Yeah.
well, which I think it becomes quite difficult to administratively manage a veterinary service if you are having to do quite a lot of things that they have to do. But do you think there's a role for tighter regulation in the UK, for example, like some of our European counterparts, or do you think we should be trusted as a profession and a wider society to start making the right choices?
Yeah, I mean, different countries have different approaches, which in itself is a bit of uh, a sort of gives a note of caution, suggesting we may not have the right formula in this country. One of my ex-colleagues, she lives and works in Denmark, and again, they have a very different system there to us because there the vets are not allowed to sell medication, so they have to prescribe things and write a prescription, and they're only allowed to write a prescription if they have made a diagnosis.
Right.
And that applies for parasite medication. So it's a different system. And one of the other things that we haven't mentioned yet is that the veterinary profession is under a bit of scrutiny just at the moment, as you well know,
Mm.
with the CMA taking a look at how our profession functions in its care of animals, and more particularly how it deals with the people that own those animals. And it's a rather an uncomfortable situation for the profession at the moment, looking
Mm.
at charging and value for money and transparency and all these things. And I think one of the issues has to be, does this monthly treatment or 3 monthly treatment or whatever it was, does that represent good value for money for our clients? Sometimes yes, sometimes not. And I think we do need to put our house in order a little bit on that. I can't remember exactly what the question was you asked me now, but
Well, no, it's really interesting you say that, and it just reminds me of what you said earlier, where your head nurse came to you and said, Andrew, I think you're going to do yourself out of business here, but actually, you proved that you didn't because of the very fact that you were building trust and delivering very transparent and honest messages to clients. And I feel like I've done that throughout my career. As you know, I've worked in some very well-heeled private practices in central London, but I've
yeah,
also taken my approach to always be very pragmatic and to only sort of recommend things that I think need to be done,
yeah,
and being very clear where I feel that this is for peace of mind rather than I don't think it's going to change our course of action. And I think that even where I worked in environments where people do have a lot of money and they're quite wealthy, I think it goes down very well. I think it really,
yeah.
builds trust. So I think
Well,
there is a
yeah,
place for it.
I, th- I I do as well, and we've also got ourselves into a situation where many clinics, for a number of reasons, have these really short consultation times. And they've really got to get their animals in and out and da da da. And it's really, really hard to meet and greet, take a proper
Mhm.
history, do your physical examination, come up with a diagnosis, come up with a treatment plan, prescribe it, dispense it, and say goodbye in 10 minutes. You just can't do it. Now, in some circumstances, that's the only option you have.
Mm.
But I would encourage vets where they can possibly to experiment with longer consultation times and accept you're going to see fewer patients, but you're going to provide a much better service. It doesn't necessarily mean the clinic income's going to drop off. And I was lucky. We had a clinic in the middle of London, like some of the ones that you referred to, perhaps, that are a fairly well-heeled clientele. But actually, um, if you as the vet have got enough time to do a proper consultation, then you're pet's owner has got a bit more time to listen to you as well and hear what you have to say and actually deal with health issues rather than just doling out medicines.
Yeah.
I think there's a strong argument for it, but it's horses for courses, and it just won't work in some clinics that rely on very high throughput.
Mm.
But it's not the only way to run a clinic.
I love how we've got onto veterinary business models. I think there's another podcast today, definitely.
Well, actually, I was speaking at a meeting in North London just recently, and one of the vets who came there said that they had recently gone on to 30-minute consults. Now, as we had done 10 years ago, 15 years ago, under most circumstances, you would think that was utter business suicide.
Mm.
How can you do it? But actually, their experience, as had been mine a number of years ago, is that actually you use the word building trust. You build trust, you have time to sort out. You're not going to just say, oh, your dog needs a dental, move on. You can have time to talk about it. And it worked very well as a business model for us. And I hope it does for these guys as well. I would strongly encourage vets who've got control over that to think about doing that in their own practice, because you're not only better medicine, you just are, right? You're going to have a nicer life because you actually have, you're not just dealing with these people on a production line. And there probably are ways of making it work financially. It did for us. I mean, it's
Unless you work for a charity.
well, yeah,
Yeah.
I did 5 years at the RSPCA. I know it's
Yeah.
where you're coming from on that
Yeah.
one.
But it's a different type of medicine, though, isn't it? In charity, we're very much working on pattern recognition and the ability to move those simple cases through very, very quickly, so
Yeah,
that you've got a bit more time to spend on the ones. So rather than that blanket set time approach, I think you
yeah,
flex your time, don't you? And you're working a lot more experience, aren't you? And evidence,
yeah,
collective evidence. I find, especially working at places like RSPCA. I mean, I worked at PDSA for nearly 20 years, and it's not just yourself. Like, I've got 5 years experience. It's like, we've got 120 years experience between us as a unit. So you're pretty confident that you can
yeah.
move things through pretty quickly. But yeah, interesting. Anyway, we won't get into the consult at times, but I do have a request from you. If I was going to ask you to give sort of one clear message sort of to pet owners, to vets, and to industry about the responsible use of parasite treatments, what would it be?
It would be just ask yourself, do I actually need to treat this animal for parasites now? Do I actually need to? Full stop. End. And if you
Okay.
do,
Simple.
fine, let's treat. If you're not sure, well, you can go to your vet clinic, you can talk to one of the nurses, you don't necessarily have to shell out for a consult. You take advice. If you think your pet might have parasites but doesn't seem ill, well, there are tests available. You can check. And I think, I hope that there will be a time before so very long when you don't get parasite treatments routinely as part of a monthly package. I think that would be great. And then that will change the question straight away. But I think we treat according to the risk. There is a distinction between hazard and risk. Hazard is the potential for there to be a problem, and risk is the scale of the problem. We're at the moment, we're treating on the basis of hazard.
Hazard.
What we should be doing is treating on the basis of risk. This animal is at risk of parasites, we'll treat it. If it's just a broad sort of maybe a hazard, now we know what we know about environmental contamination. It's no longer acceptable to treat just on the basis of hazard. That we need to be treating for risk. It's a sort of a nuanced difference, but it's a really important one.
Yeah, it just sounds very sensible when you say it like that. So I do have one final question for you, Andrew, and I ask all my guests this. Is there a pet or a person who has inspired you in your work over the years? Who are they, and how have they inspired you?
Yeah, you gave me a little heads up on this, and I hadn't been thinking about it. My first person that came to mind was Mr. Briggs, my biology teacher at school. And I probably haven't mentioned his name or even thought of his name for a very long time, but he got me going on the transition from liking nature to being able to study biology. And that was the first one. The second one, I guess, was my first cat. My first cat, who was a ginger Tom stray, came into my first clinic.
What was he called?
Well, he didn't have a name, but I called him Caligula,
Wow.
the Emperor Caligula.
I was gonna expect Garfield or Ginger or something like that, but you went very highbrow there.
Well, there'd just been a film. The film had just come. The Caligula film with Malcolm McDowell had just come out, and so I just thought. So I called him Caligula. Anyway, but his nickname, because he was a ginger Tom, his nickname was Agent Orange. He was a good guy. He was a great cat. In the veterinary field, well, the legendary Dick White was pretty high on the list. I had much early in my career, I'd had some contact with Dick, but not much. And I remember ringing him once and saying, "We've got this case at the RSPCA. It needs a total ear canal ablation. I've never done one. I don't know where to start. Nobody else at the clinic has. Can you help?" And he said, "Right, what are you doing next Tuesday? I'll come down to the hospital and I'll do it in your hospital and show you." And which is exactly what he did. And he came over to the hospital, and he was very nice, an incredibly good surgeon, so fast, so efficient, so neat. And I just thought, yeah, good man. Good man.
Do you know, it's really interesting to say that. I've just had my last guest on the podcast said something very similar, that the profession is great because you can reach out to pretty much anybody in it and get help from some of these most, fantastic specialists who are doing such amazing work. And very rarely would you ignore an email from somebody that's asking for a bit of advice or a bit of help. We had recently, obviously, I work at Blue Cross. We recently did a PDA surgery on a puppy. Patent ductus arteriosus. So, open thoracic surgery, heart surgery on a very, very little puppy. And again, we had a specialist that came and donated their time and took our team through it so that they had the skills and expertise to do it in future. So, I mean, it happens. It's great. It's great.
It is really good like that. I mean, I think, and the specialists are so often incredibly helpful, and willing to give their time and energy and expertise. And well, that'll be my names anyway.
But, thank you so much for joining me. It was such an interesting conversation. And I think it's really sort of brought the science to life a bit, and I like this sort of sentiment that, the question is not whether we should treat. In some situations, we absolutely should. But how do we do this more responsibly? So, it's great to have you on the show, Andrew. Thank you ever so much.
Thank you very much for inviting me.
Fab.
Thank you for listening to this episode. You'll find all the relevant links to this conversation in the show notes. If you enjoyed it, please follow us and leave a review. It really helps other people discover the podcast. For more insights on topics like this, you can connect with me on social media at Dr. Paul the Vet, or check out my website, theconsultroom.co.uk.